Urology, prostate cancer, is a multidisciplinary, heavy field, and it does require dialogue with your colleagues.
There are a lot of different types of metastatic castrate-resistant prostate cancer patients. So not all of these patients present the same. And so I think the first thing to do is really look at the individual patient and look at the biology of the tumor itself. In the more aggressive, kind of faster growing tumors, things like chemotherapy, but also AR-targeted therapy can work well, including those patients with visceral metastases. But again, that's something you have to assess over more than just a single point of time. So really get a look at the patients, the tumor kinetics, but then also fold in any comorbidities or other things that might impact your treatment choice.
Yeah, I think a lot of the drive is trying to identify patients early when they're metastatic and castrate resistant, whichever tends to happen or change, and then also to continue to track them and identify when things are failing so we can move on to the next therapy as appropriately as possible. So there's a lot of data mining. There's also a lot of face-to-face interactions, trying to have fairly frequent visits with these patients.
As a urologist, we've gotten more and more comfortable managing castrate-resistant prostate cancer patients. And so I think in the last couple of years, there's been a lot of acceptance in our field, different than medical oncology in terms of managing advanced prostate cancer. So it used to be I would feel comfortable giving androgen deprivation, no problem. Even switching the deprivation, giving anti-androgen pills, but rarely advanced AR therapy. And then that became a comfort zone for me and for the field as a whole.
In our practice, we really approach metastatic castrate-resistant prostate cancer in a multidisciplinary fashion. So very much incorporate not only our urologic oncologists like myself, but also our medical oncologists very early in management of these patients. Although there's a wide spectrum of different management options, we recognize that not any two patients are exactly the same. So really in a personalized approach to each patient's care.
We certainly do collaborate with radiation oncologists and medical oncologists and urologists in a multidisciplinary fashion. Genitourinary oncology, prostate cancer is such a multidisciplinary, heavy field that we do require and have our colleagues assist us with treatment for these patients. When I see a patient on initial consultation, I take several factors into consideration. One of them would be their performance status, their age, the amount of disease burden that they have, tumor burden, their metastatic disease sites. And when you formulate exactly and place a treatment plan for those patients, it really depends on how much disease you're treating and what kind of response rate you want from initial treatment. That's how I formulate my metastatic castrate-resistant prostate cancer patients as far as what treatment plan to use, whether to use IV systemic therapy because you need an immediate response, or to use androgen receptor antagonist therapy with androgen deprivation therapy combined. And so it really depends on the patient and essentially how much disease burden they have and their performance status so that they can tolerate their treatment. Because the overall goal, and I tell my patients this, is to give you the best treatment with the best quality of life with the best results. And that's what we try to achieve.